How is everybody? Hot? I know, right? We had soccer practice yesterday. And it's like, I don't want to. It was so hot. It was almost like muggy too. I think it's because of the tropical storm like we're supposed to have. There's a chance of thunderstorms tonight. There's a really big chance of thunderstorms tomorrow. So it's kind of exciting. And Friday, like rain and thunderstorms. I'll take it. All my little soccer kids were like, "Are we gonna practice if it rains?" I was like, "Uh-huh, and that'll be fun. As long as there's no lightning. Like there's lightning, then it's not safe. But the odds of us having a lot of lightning feel pretty low." Anyway, I wrote a bunch of reminders up here on the board. I was realizing this morning that I won't see you after today for a couple of weeks. And that makes me really sad, right? I'm not excited to be gone. I'm not a like, I can't wait to miss kind of person. Like I have severe FOMO in life, right? Like I like to be everywhere all the time. But I wrote this stuff up here, so I want to go through everything. That's up here one more time. And thankfully the internet is working today, so I can record this. The Wi-Fi didn't work on Monday and it was a pain, but it's working today. So that's good. So a couple of things, right? So on Monday, this would have happened no matter what, right? This would have been how it went on Monday either way. But Monday we have exam number 1. Okay, and I know exams cause people a ton of anxiety, but it's open notes, it's open book. You have a study guide. I want you to do well, and I will never trick you. Okay, I'm gonna put all that out there, right? Just to start with, so you can hopefully take a breath. Yeah. No, right, so it's just on campus. I find that to be a pain. I understand why people use it, and we probably should, but no. I'm going to trust all of you. You're like, no, you're shaking your head, right? It's a pain. It's
Just like
complicated.
just because like, I don't know, it updated.
No,
Literally any movement at all gets you black.
I know. Yeah, we're not doing that. So during COVID, I always used to give my exams in person on the day, like normal. But during COVID, I transitioned to online. Honestly, people have so much test anxiety, and I'm really sensitive to that. So I want you all to do well. I want to make sure you understand the materials, but it doesn't need to be artificially harder than it is. So, what will happen on Monday is we won't have class. That'll be the case every time there's an exam. We don't have class that day. And you have this class time to take the exam. Or if you would rather sleep in, have a nice cup of coffee, have a nice snack, right? I'm telling you what I would rather do, right? You are welcome to do that. You can take it any time before 11:59 p.m. that night. So it's open all day. Okay, but please don't miss the deadline. It will close at midnight and it's gone. Okay, so if an emergency happens on the day, on Monday, if like something happens that was completely unexpected, if you reach out to me before the deadline, I will work with you on it. If you reach out to me at like 12:02 a.m. on Tuesday, it's too late. So that's my one like hard rule. If something happens, if you're like violently ill, you have an emergency, I understand I'll be in surgery on Monday. So like talk about emergencies, like I get it, right? But if something happens, just make sure you email me before the deadline, otherwise it's too late. But otherwise, assuming everything is fine, it will open up on Canvas. So it's right here where it says quizzes. I can't change that to exams, but if you click on quizzes, it'll bring it up. It says right here, exam number 1. And when it's time, you'll click to start on it. It's not open yet. Okay, but when it's time, you can open it up. It does have, it's worth 100 points. It's 75 minutes that you have to complete the test. You only get one attempt. So when you start, make sure you're ready to go. Okay, ready and organized and ready to go. What I mean by that, some little like pointers. Make sure you have 75 minutes. Make sure you have good internet, a quiet place to take it, or like headphones or something so you can drown everything else out. Make sure you've prepared, you've studied. I recommended last time that you do the study guide. If you click on modules, the study guide's right here. Study guide for exam number 1. Basically what I did is I went through the test and I wrote every term on here that you need to know. Okay, so without the questions, these are the terms that are on the exam. If it's on here, it'll be on the test. If it's not on here, you don't need to worry about it. Okay, so it's chapters 1, 2, 3, 4, and 5, which we'll finish up today. So it's those first 5 chapters. What I always tend to do, and I'm an over-prepare, as I mentioned or shared last time, what I would probably do is write or type these out and have it in front of me. Because you don't want to be trying to find it in the book, find it in the notes, find it in the slides. It's going to use up your time. Okay. And if you're trying to look up every answer, you will run out of time. I haven't made the test any harder, but if you haven't studied, you might struggle with your timing. Okay. And that's where you might end up losing points. So just make sure you know everything on here. And you should be in really good shape. The second you submit the test, you'll get a score, except for the short answer. And normally I grade those throughout the day. I'm having surgery sometime on Monday. I still don't know when, which is driving me absolutely bananas, but that's another story. But I won't probably be grading them until like Tuesday or Wednesday. So forgive me for that. I'm normally like really on it. But you'll get a score for everything but the short answer ones at the end. And the short answers, like we've talked about, they're never going to be essays. It's like, what are the 5 Ds of abnormality? They'll be lists, not essays of any kind, ever. Okay? So make sure you know everything that's on here. And again, make sure you complete it sometime on Monday before 11:59 p.m. And the study guide, as I said, was right here under modules. Some of you have access accommodations. It should be all set up, where you have your extra timing already put in there. If for some reason it isn't, feel free to email me and we'll adjust it. But it should be all fine. Are there any questions about the test? Anything about the exam? I don't want to downplay because I know exams, they're worth a lot of points, but as long as you understand and know everything on the study guide, you'll be in good shape. There'll never be a trick question. So if it's unclear, try and read it again. Trick questions are the worst. You're already anxious. It's like, let me make you overthink it, right? I won't do that to you. And I think I mentioned this last time, but if not, it's mainly multiple choice, true, false, and then there's some short answer questions at the end, which are like, again, what are the 5 Ds of abnormality, or the 3 of these, or 4 of these? I love those little lists for the short answer questions. Okay. Anything else? Feeling okay about it? As okay as you can about a test, right? Nobody's crying, so that's good. No, I'm just kidding. All right. The other thing, and I wrote it up here, and I've been mentioning this too. So Monday I won't see you, and then we won't have class Wednesday, Monday, Wednesday. Okay, so I met with my surgeon on Monday, and it might end up being longer than that. I hope not. He said they won't know until they get in there and open up my knee. He's like, if you wake up with a massive scar, you'll know it didn't go well. Thanks. Right? So he said they're supposedly just doing my ACL, but if they have to do my MCL, I apparently will have a scar like all the way down my leg, and I'll be out another week or two. So I will keep you posted. I'm really hoping that's not the case. He said I might be able to come in if I sit. And like, oh, that's awkward. I'll just pull up a chair and stare at you right here. But I don't know. So if that's possible, if it's possible for me to be here, but I have to sit, I'd rather be here. So I will keep you posted, but that is our plan for now. If it changes, I'll let you know. Just be making sure that you check your Canvas announcements. I already have made some lecture videos. I've already set up the assignments. Everything's ready to go. So you'll get announcements as we go through with some little things to do, some little videos to watch. And I think there's one assignment that I gave you to complete, just so we don't fall behind and have to skip some chapters. Okay. Anything? Yeah. What's Yeah, there's a flex day in there, right? Yeah, October 8th, right? Yeah, there's no school that day. So I'm hoping that we come back on the 6th. Yeah. And then we can have that day before we lose the 8th. Worst case, if they have to repair more than they're planning, I'll probably miss that day. But I'm hoping to be back that day. We actually have a guest speaker who's going to come that day. So I can sit and watch them stand. So hopefully we'll be fine. But the 8th is a flex day where there's no school for all of you, but we have to come and do class, which is kind of fun. They usually give us food, so I'm fine with it. I'll do anything for food. All right. Anything else for now? Other questions? Anything about any of that? Okay. If you think of anything, can ask me at the end or email me, of course. Like I'll still be checking my email. Feel free to email me if you do have questions during that time. And again, I'll keep you posted if anything changes. Otherwise we'll go back to stress, right? Yeah, back to our stress disorders. Yeah. So I believe there's only one assignment that I'm giving you. So there's 2 chapters that we're going to cover while I'm gone. It's the like somatic symptoms and then mood disorders. And one of them has a assignment with it. So I think it's just one like case study that you'll do. And it'll be due by the end of that day that I fixed it. And then there's a couple of videos for you to watch. I like recorded a lecture video this last week on that topic so that we didn't fall behind and you didn't lose coverage of it. Okay. So we left off here, right? We finished talking about ASD and PTSD, and then kind of started to introduce this, but we were out of time. So one other disorder that has gained a lot of traction, and I mentioned this last time, it's not in the DSM yet, but it will be, is complex PTSD. And with this disorder, rather than like one big trauma, one big T trauma, we're looking at a bunch of little traumas, or we call them little T traumas. And it's often related to childhood, as we were talking about last time. And what it does is it leads to a lot of like long-term issues, a lot of long-term struggles with relationships, self-perception, emotion regulation, when you're struggling to like maintain and control your emotions. It can lead to what are called emotional flashbacks as well, where you kind of have like this feeling almost like you were thrown back into an event that happened to you years ago. And it has these criteria, but again, they're kind of still evolving because it's not something that's official yet. But a lot of people have been writing about it and talking about it. Really interesting book. I finished reading this on our last cruise we went on. So sitting there reading it while eating way too much. But I'll pass it around. It's called What My Bones Know. Somebody's memoir about CPTSD. Really interesting book. Been trying to share the books related to these with you whenever there's a good one. But talking about kind of her own experience of working through this and like being diagnosed with it. And I have a little video that kind of talks about the criteria. So let me play that for you. And then we'll come back and talk key pieces. So as it stands right now, since as I told you, it's not its own separate disorder, if somebody has symptoms that match CPTSD, they'll diagnose them with PTSD not otherwise specified. Okay, so that's what the diagnosis would be right now. In the next DSM, in there, it's getting a lot of popularity, but that's what it would be right now, since it doesn't exist yet. Yeah. We'll get there, right? It's in our second like half today, because those are both things that happen with this and with the flu. So we'll get there. Glad you asked. So again, this has a lot to do with like lack of safety, sometimes attachment trauma in childhood, very like childhood based, but a little different in the way that it presents. It's not one trauma, it's lots of complex issues. So a little bit different than like traditional PTSD. So in terms of all of these, ASD, PTSD, CPTSD, lots of letters, a trauma by itself is enough to cause a disorder. But not everybody who experiences trauma develops one of these disorders that we're talking about. So there are some biological and genetic factors that are in play, right? It's possible that maybe you don't respond to the same level of severity, right? Or you respond more intensely than the average person. People's like responses to trauma can be a little bit genetic in the way that they tend to have a propensity to over respond or under respond. Your personality plays a big role. Some people can handle an incredible amount. Some people are just incredibly resilient. Other people crumble at very, very little. My mother-in-law is one of those like wonderful, sweet, kind people, tiniest little things, she's like in pieces, right? Like versus my father-in-law can handle everything in the world, right? Like you could just throw everything in the world at him and he soldiers right on. Her one little thing, done, right? Like people are all over the place in what they can handle. And so there tends to be like a resiliency factor. The number of childhood experiences that you had, the amount of support that you had through them. Let's say that you had really big issues with safety and attachment, but there were other people there to help and support you. Grandparents, siblings, maybe one parent was okay, but one wasn't. All of those things can like play a role. And then how much support did you have after a trauma? Did you get into therapy? Did you process it quickly or did you just kind of shove it down? There's also a lot of cultural factors. Like we see certain ethnic and racial groups and poverty-stricken groups tend to have more PTSD than groups that don't, right? And then obviously the severity of the trauma. The more severe, the more likely you are to develop a disorder. So lots of different kind of elements to this, but a trauma by itself can be enough just on its own. But these things can kind of mitigate whether or not someone develops a disorder or not. Any like thoughts or comments or questions or anything before we talk a little bit about treatments? Anything so far? Mentioned this in that little clip, but when it comes to treatment for ASD, PTSD, CPTSD, we like to use EMDR, right? More letters, lots of letters again. But we can use medication to help people with anxiety and like stress response. But typically, when someone experiences a traumatic event, you need to deal with the traumatic event in order to get better. Now, that's not always fun to do. It's not always easy to do. And with complex trauma, you're dealing with multiple small events that you may or may not even remember. Attachment, we're talking about the first couple of years of life. You might not remember what happened, but you have to like deal with the feelings and associations that come with it. And one of the ways that we can do that is through a treatment method called EMDR. Anyone in here like know someone who's done EMDR before, yourself or someone in your life? A lot of you, it's become very popular. It was developed by accident, right? It was kind of discovered by accident. The woman who invented it, Dr. Francine Shapiro, was walking through a park one day, thinking about like some trauma and stress in her life. The trees were passing by the side of her, and like she noticed that she felt better. And she started to like do some investigating. Was it the being outside? Was it thinking about the trauma? And one thought that they had was it was the passing of the trees and the movement by her eyes. And so they started experimenting with this like back and forth, like rhythmic bilateral stimulation, it's called, trying to get your eyes to go in this like saccadic pattern. And something about doing that while thinking about the trauma helps you to digest it and work through it faster. Really like fascinating, very like can be a little bit long to do, right? It can take multiple sessions, just especially if it's complex rather than like one trauma. You can do bilateral stimulation with the eyes. So the old standby was the therapist would hold up two fingers and go like this, like for hours. But the therapists were getting like arm issues, elbow issues, and so they developed a light bar, and the light just goes back and forth. The other way you can do this is you can hold tappers, and they buzz in each hand, and that stimulates you bilaterally as well. For some people who maybe don't want to stare at a light or want to close their eyes as they try and like picture these things that are coming up. So there's a couple of different ways they can do it, but the idea is that you bring up the trauma and you think about it, think it through, and this helps you to work through it faster. Another little one of those videos kind of talking about it, I'll play it for you. It just kind of shows you a little more of what this looks like and the process of it to do and to work through these things that come up. But it can be incredibly helpful. You take a belief that you have about the trauma. I have no control, right? It's my fault, whatever that thought is, and you slowly change it to I have control now, or it's not my fault, right? You're working on whatever like negative belief you have and trying to change it, getting rid of the sensations that you feel related to the trauma. And you just bring it up. It gets harder before it gets easier, right? So it can be difficult to do, but oftentimes people who do it successfully will feel so much better. So, yeah.
Under what type of therapy?
So it's its own specific like alternative therapy, but it's usually within the realm of like cognitive behavioral therapy. If we had to cluster it somewhere, but it's considered an alternative therapy. And not all insurance is accepted because it's alternative, but it has gotten more evidence to support its efficacy than it had 5 years ago. So it's becoming more popular than it used to. Yeah. Yeah.
That like.
Possible, yes. The best way, no. Okay, so hypnosis, wildly interesting. If any of you've ever been hypnotized, right? Like very interesting. It's also a very like pseudo-scientific state. Okay, in the sense that you are incredibly suggestible under hypnosis. And so oftentimes the things that you remember may or may not be accurate. And you can end up doing more damage than good by causing someone to remember something inaccurately. It's used, but it's not super common for trauma. It's more like for habits. Like if you want to get someone to quit smoking or quit like doing something like that, like sometimes it's used, but it's not it's not scientifically validated, so it tends to be very like questionable. If Mhm. Yeah.
Let's roll that. Yeah, really stable.
Yeah. Right, and we don't tend to remember much of anything before the age of two, childhood amnesia, childhood infantile amnesia. So the likelihood of that, like, I mean, just even saying it, right? Like everyone kind of has that like, right? Like, and that's like the attitude that tends to come with taking it there. And so this is much more validated and like empirically like driven. People use hypnotherapy, but it's not as effective because people can remember things very inaccurately. Not to say that that doesn't matter, right? If that's his or her like memory, you could work through that and it could be meaningful. But is it the most like effective, you know? Yeah.
Hypnosis affect the accuracy more than just recalling normal.
Because you're in a very like semi-conscious suggestible state. So the way that you ask the questions can be enough to shape it.
But
Like
isn't that how it is?
it
You know, I
could
mean,
be.
that's the whole thing about it not being good in legal cases.
Yeah, and it's, but you're more aware when you're consciously alert than you are when you're in a sleep. So something like, you could ask somebody like, what did you do on that day? Or what did you do after X on the day? And X might not have ever happened when you planted that idea in a hypnotic state. So it's just, that when you're awake and alert, you tend to have more of a cognitive filter than you do when you're under the. And so, I mean, it can be really helpful for people, but it also can have some like effects like that that are a little questionable. Much more suggestible, much more so. Yeah.
How people and, brothers, working people who do.
Yeah. So it bilaterally, the whole thought initially was that it had to be the eyes, right? But with the bilateral stimulators in your hands, it buzzes back and forth on each side. And so it still creates in a different cortex of the brain that like stimulation that's bilateral. It's not thought to be quite as effective, but some people don't do well with like the distraction of staring like this and trying to think through whatever happened. And so the advantage to the buzzers is you can close your eyes, which helps a lot of people to visualize better. So it's kind of like a personal preference. Typically, they start with the eyes, but if somebody struggles with that, you might move to the hand buzzers. Yeah, yeah.
Isn't that sort of what rocking does? Like when you rock a child and they're like, oh, and I didn't get picked for the, kickball team or whatever, and you're doing that kind of. Right,
Yeah,
it's
more like a
okay, and they're,
Self-soothing kind of behavior, like.
but it's still bilateral, that kind of like, I mean, that's what you're like, yeah, it'll be okay. I mean,
More
I
than
would-
bilateral, it's rhythmic, right? And there's something rhythmic about the about these as well, but the thought is by like right, left. It activates those different cortexes in the brain in a way that's like different than like a slow, steady, like soothing movement. But there's probably threads in common between them. It's just a different, they're trying to activate the brain versus soothe the brain. Different like angles, maybe. A little bit, yeah.
I was gonna ask, like a high recommend.
Yeah,
If it has any links or if there's been any study of to sleep, because I know that when you get like, the deeper states of sleep, your eyes are very similar in that very same state.
Yeah.
And my question is more of like, is
EMDR.
Yeah,
Right.
yeah.
Mhm.
Is that essentially the same state that your body would be in sleep and cognitively, but
Sure.
when they're awake?
So REM sleep, right? Rapid eye movement sleep is when you dream. And when we dream, we notice our eyes flutter, right? They have rapid eye movement, hence the name. And that's one of the biggest hallmarks of dream sleep. You can also see it on something like an EEG, where you can see the brainwave pattern change when someone's in a sleep. Now they've done EEGs on people who are under EMDR, right? And look at REM, EMDR, EEGs, right? Why do we have to shorten everything, right? But it makes it, I guess it makes it easier. But when we do those brainwave patterns, we can see that it's similar, but they're not quite the same. Right, so you're awake, like you're completely awake and alert. You know what's going on. Sometimes people dissociate, we're about to get into, but it is typically that you're completely alert and awake. It's a different state, but you are experiencing some of that eye movement, which is a little similar. Yeah, sure, sure. So these ones, really uncommon, but fascinating. Dissociative disorders. There are things like dissociative amnesia, dissociative identity disorder, depersonalization, derealization. All of these involve some kind of form of memory loss, not being aware of your surroundings, feeling separate from yourself, changes of identity, or even more than one identity. Okay, so there's a bunch of different disorders in this group. We'll talk about some of the common ones. Yeah.
There are any disorders that are almost always like accompanied by drugs or something like outside?
How do you
I mean, like if you're also taking drugs, you're more likely to like most people who have this disorder are taking some kind of drug.
So there are drug-induced disorders, which we'll get to in it's like chapter 10, I think it is, where it's specifically due to the use of the substance. So that might be kind of what you're getting at, maybe. But yeah, there are disorders that are induced or caused by substances. Like schizophrenia can be one of them, for example. So one relatively common form of dissociative disorder is dissociative amnesia, where people lose memory for past events without any kind of physical cause. Okay, there's so many examples of movies. I always think of like Ravel or 50 First Dates, right? Movies where somebody hits their head and then they have memory loss. That is not this. Okay, so when someone hits their head, has a head trauma, and experiences memory loss, that's called retrograde amnesia. And it's due to the head trauma. This is memory loss due to emotional trauma, psychological trauma. That's what we're covering, right? So it's without physical cause. So this is somebody who experiences something traumatic or stressful, and they lose memory, not because of a physical trauma, but because the event itself was traumatic, emotional. Yeah.
So like if a child and like you asked the child, hey, what happened that day, and they're like, I don't remember because that day was traumatic in a sense, was that?
Yeah, well, that would be this, right? Now, if they had like, they hit their head and they don't remember, not, right? So if there's any kind of like
kind of thing, they just,
yeah, you're dissociated from it. It feels far away or blurry, and maybe you don't remember it clearly as a result. When we go through a traumatic event, sometimes we don't remember it clearly. It can take a while for it to come back, and that's very much this. Yeah.
So could it be like a coping mechanism?
Yeah.
Like depression?
Yeah, right. Like, so you don't allow yourself to remember it because it was traumatic, right? And so in a way, your brain's trying to protect you, right, from experiencing the pain of it. But in order for it to go away, you have to work through that pain, unfortunately, right? Like with trauma, you have to work through it in order to get better. That's the sad reality of it. And so what can happen is we can get 5 different types. And like, this would be a great short answer question, right? Like, what are the 5 types of dissociative amnesia? Those are the kind of questions you'll see. So localized, selective, generalized, continuous, and fugue. I will not ask you the difference between these, except for maybe fugue, which is underlined like its own term, because there's not a lot of like clear division. So it'd be a great, like, what are they? But I won't ask you the difference. So just know that in your mind because they overlap a lot. But localized is when it starts with like a severe disturbance of some kind. So maybe you have something traumatic happen and you remember some of it, but not all of it, right? Like you just tend to remember bits and pieces of it, which is very commonly correlated with selective. Selective is when you tend to remember, like, again, like some, but not all, right? Localized is when you tend to remember the beginning, but not all of it afterward, which is, again, why I won't ask you the difference between them. Generalized and continuous are really rare. Generalized is when you forget before the event. Okay, so like you don't remember what happened before the traumatic event. You forgot your personality, your identity. Like, let's think of the Bourne Identity movies, right? Like he can't remember who he is, right? Like you forget everything before. Continuous is when you forget everything after. You can't make new memories. So lots of different ways that we can forget when something traumatic happens. This one is probably the most fascinating. Dissociative fugue. Right, Penga. Fugue is Latin for flight. This disorder, it's its own specific disorder. Somebody experiences something stressful or traumatic and they leave. They literally flee. They take off, travel a long distance away from home, and something about the journey and the process of leaving, it's almost like they leave their identity behind temporarily. They forget who they are. They end up in a new city with no memory of who they are. This pops up in the news every now and then, and it's almost always related to like extreme stress. I found a news story, it's a few years old, but this guy, like he has no idea who he is. And they oftentimes appear this way because as you leave and go on this journey, it's almost like you just forget who you are. You have no awareness that you're doing it. It's not like I'm going to go take off and pretend to be someone else. You enter into like a sort of fog and you can't remember your identity. Usually what happens is you start to have this feeling like something is wrong. You don't have documentation to support who you are or what you think you are or like where you think you are. And so you end up at like a police station, you end up being discovered. But it is something that sometimes happens. It's typically in response to like a stressor or a trauma. People take off, they flee, they take off on a travel. The travel piece is a big part of it. They go somewhere far from home and they assume a partial or complete new identity. Doesn't tend to last, but it's something that sometimes happens. It's a very rare form of dissociative amnesia. Really interesting, but really, really rare. Yeah. Yeah. So it's what they probably gave him is sodium pentothal, which gives like a hypnotic effect. It's sometimes informally called truth serum because it puts you in like a hypnotic, suggestible state. And so the thought behind it is that it will get you like past your cognitive filter a little bit so that you tend to like answer more freely. Whether it actually gets you to the truth is debatable, but that's probably what they gave you. So sodium pentothal is like a sedative hypnotic drug that mirrors the closest thing we probably have to truth serum. So these ones are one way this can manifest. Another, let me see, oops, sorry. As you had asked earlier, depersonalization and derealization. These are actually elements of a lot of different disorders. A lot of disorders have these two pieces to them, or you can have just these as its own disorder. Yeah. Yeah. Yeah.
So selective.
It's
almost like in consciousness, whereas the world was the block of time.
Yeah, so it tends to begin with whatever happened. Like, so oftentimes, like, okay, so during like the 9/11 attacks, for example, selective would be like, I remember like getting out of the building, but I don't remember how I got into the ambulance. Like, you remember bits and pieces, right? Versus localized would be like, I remember when the plane hit the building, but nothing happened. Like, it's kind of like everything from the event on. But again, I won't ask you the difference between them, but yeah. So these two they can occur together or they can occur separately. Depersonalization, derealization disorder is when people either have one or the other or both. And you often feel very outside of yourself with these. Now, you can experience this from a drug or a medication, so that would exclude you from this diagnosis because it'd be due to the drug. But depersonalization is when things with your own body feel very unreal. It's like you feel detached from your person, right? Depersonalization, you feel separate from yourself. Derealization is when the world around you feels unreal or detached. So like you almost feel like you're in a fog and everything around you feels far away and unreal. Versus depersonalization, you feel disconnected from your own body, right? And again, these can happen with PTSD, with CPTSD, with depression, with schizophrenia, with a lot of different disorders, or it could be the only thing that you have, and it could be its own separate disorder. But kind of a little bit different in that one is separate from yourself, and one is feeling separate from the world around you. And think about depersonalization, you feel separate from your own person. Okay? Like you feel far away from yourself, almost like you're dreaming or like in a hypnotic state, like you're watching yourself from a distance. And again, these are common things that people experience, but it can be its own disorder or elements of the ones that we're talking about here. Thoughts, comments, stories, questions, anything for now? Yeah.
So like if you're remembering things and you
Yeah.
remember it from your own perspective, that you can see yourself better after watching it.
Sure, right, and it happens a lot, like, so, let's say somebody's doing EMDR to work through a traumatic event. It might be that as the trauma gets more intense as you're bringing it up, all of a sudden, everything feels far away. Right, really common that traumas will trigger these things into action. Again, it's almost like you're asking like a defense mechanism. Your mind is trying to protect you from that pain by making it far away. And so as people are working through a trauma, sometimes all of a sudden they'll be like, I feel like really like out of it or like foggy or confused or like everything feels far away. It's a big like stop. Like it's a fast, hard stop, right? Like the therapist would have to like stop doing the EMDR, bring you back to reality by grounding you, feel your feet on the floor, take a breath, focus on this, focus on now, trying to bring you back to the moment. That happens a lot in trauma work. It's very, very common. Yeah.
Is it like ever successful if your brain forgetting about something? Like maybe you literally have no recollection period, like even when people maybe that experience it with you bring it up, like isn't that like kind of it being successful, it's not affecting them?
Yeah, except what happens is when you repress something for a long time, it tends to come out in other ways. Physical symptoms are really common. So like people who push their trauma away and it's really far away, that might help for a time, but then they start having stomach aches or headaches or like physical symptoms. It tends to come out in some way. So again, the leading thought, as unfun as it is you have to work through it in order for all of that to go away. So you kind of have to get into it and make it worse before it gets better. But in the short term, it might be adaptive. The other really big one here, this is probably the most famous in this category, dissociative identity disorder, DID. Anyone know what this is commonly known as? Commonly known as, yeah. Multiple personalities or split personalities, they changed the name to dissociative identity disorder because it's thought that you have these dissociated, unconnected identities. They're fragments of identities. It's not a full personality. Again, with this one, same as this, it's not on purpose. You don't do it on purpose, right? But what happens is oftentimes due to trauma or extreme stress, people will develop separate sub-personalities or identities that routinely take over their personality in person. And depending on the relationship between these identities, it really dictates how easy this is to live with or not. What can happen are kind of three different patterns. People can have what's called mutually amnesic, which means that none of them know about each other. A doesn't know about B, and B doesn't know about C, and C doesn't know about F. That one is by far the most difficult to deal with because when people switch personalities, they have no memory of what happened as the other person. In order to treat it, you have to wait for each personality to emerge and talk to each one separately. Really, really challenging to do. The second one's the easiest. When they're mutually cognizant, they all know about each other, right? A knows about B and B knows about F and F knows about S. Like they all know about each other. You can actually switch on command with B or with two, right? With number two here. You can say, I'd like to talk to this personality because they share memories, that personality could come forward, right? Really simple to treat in the sense that they share memory. And so you can bring them forward. The most common though is the last one. There's like one dominant personality. The dominant knows about all the subs, but the subs don't know about each other. So A knows about B through F, but B through F don't know about each other at all. Okay, so again, the hardest to work with is when none of them know about each other. Easiest to work with is when they all share memory. And the most common is when there's like one dominant personality. Yeah.
Like.
Yeah, and music, yeah.
Yeah.
It's a hard one to say, right? For me too.
Can that come, like, can people aware of each other or?
Yeah, they can change their pattern of knowledge. It often takes a while. It's like educating each one of them, and as you educate each one, then they start to understand that there's connection. But it takes time, and you have to wait for each one to come forward to do so. So it can be a very lengthy process to do. Yeah.
That's the dominant.
Yes, but the other ones don't know about each other. So A knows about everybody else. Yeah, usually, right? They kind of have that like I'm in charge. And so then you have to work with A to access all the other.
Are there characterizations that are associated with identity disorder that present in the but do not as severe or are they distinct?
Borderline personality disorder is a really like intense personality disorder. We'll get there, obviously. But with that one, the reason they call it borderline, as a side note, is on the border between neurotic and psychotic. Can't control your emotions versus not aware of reality. And so for some people, it can be so severe that it might have elements of depersonalization, derealization, but it's not the most common to see it. The one that this is always confused with is schizophrenia. Okay, so schizophrenia, one personality, but the connections in that personality are fragmented, right? They see things that aren't there, believe things that aren't true. With this one, it's more than one identity. So we could get wild. One of the identities could have schizophrenia in theory, right? We can make it really complicated if we wanted to. Yeah. Split. It's so, right? Like I'll say the portrayal of it is so,
And it is,
right?
like, innocent.
Yeah, and there's lots of superhero movies. There's a lot of movies that feature this. One of my favorites that features this, and it's not obvious until later. I don't know if any of you have seen it's perfect for this time of year. Identity. It has John Cusack in it. He's like the main guy. Huge twist. Really good movie. I'll leave you with that. You have 2 weeks to watch it until I see you next, right? But really interesting. Another one of my favorites, and I have a clip from it, Bates Motel. Love that series. Love it so much, right? Norman and his whole story told through this lens, right? Really cool, right? Really cool take. Yeah.
Is
Oh,
there
okay.
like an explanation for the subpersonalities or are they just like random?
They usually serve a purpose, right? And so maybe you'll have one who's really outgoing, one who's really passive, one who's a child that the trauma happened to, one that's an adult that protects the child. They oftentimes have a function or purpose. And when you eliminate the function or purpose, that identity tends to go away. So it's part of how you treat it. Called fusion.
Are there like common ones across people like that have this disorder, like common personality type?
The commonality is more like trauma, right? It tends to be rooted in like trauma. Something really severe happens, you can't handle it, so you create another identity that can. I would say that's the biggest theme. This is a very uncommon disorder. It's been portrayed a lot in the media, but it's really uncommon. Did you have a question, Sil? Did I answer it?
Oh, yeah, sorry, that movie Split.
Split, yeah. Yeah, right, because there's like one dominant, if I remember correctly, right? United States of Terror was another show that had a lot of this. Me, Myself, and Irene, not the best portrayal, but another one. Like, there's so many portrayals of this. So anytime there's more than one personality, that would technically be this. I ran into this once in my work as a therapist, and it was I have time. I'll tell you a story. Let me tell you a story, right? Okay. Nobody said yes, but I'll tell you anyway. Right? So when I was training to be a therapist, my very first client had this. And I didn't know it, and she didn't know it. It's memorable. I'll never forget, right? So I met with this young girl. She was in college, and she was struggling with being away from home, right? Really introverted, really shy, was struggling to make friends, really like timid, quiet, mousy, That's how I would describe her. We met for like 6 weeks. Every time she came in, quiet, shy, tell me how she's struggling. She missed her family. She wanted to go home. She wasn't making friends. Very similar, 6 weeks, all the same, right? And then on like the sixth or sixth, no, on the seventh session, she came in. Sorry, my kids have really condition there. On the seventh session, she came in and was like a completely different person. She came in, she was dressed differently, she was loud, outgoing. She was talking about people she had never mentioned. I was so confused, like it was odd. Like I was like, okay, maybe I'm seeing like the other side. Maybe she has bipolar disorder, and I've seen the depressed side for 6 weeks, and this is a manic episode. It's kind of how I felt at the time, because she was like really, really quick, like really loud, talking about all these people, all this stuff that she was doing, all these people she was hanging out with, and I was like, wow, it sounds like it's been like, like you've had a big change this week. And she's just like, oh yeah, like things are great, like just through the roof, right? It was so odd. I made all these notes. I talked to my supervisor, because you always talk to your supervisor when you're training, right? So that you don't end up doing harm to somebody. And we agreed, bipolar disorder, finally saw the other side. She comes in the next week, and she's back to like quiet, timid, mousy, shy. And the first thing she says to me, I want to apologize for not coming to our sessions. Right. Yeah, right. And I was like, no, well, you were here, but I'm glad you brought it up. You were really different last week, and I wanted to talk to you about it. And she's like, no, I wasn't here. I don't remember where I was, but I didn't come, and that's not like me, and I'm really, really sorry. Like, it won't happen again. I was like, no, you were here. You take notes as a therapist typically, right? I pull out my notes and like, you talked about this person and this and this and this and this, and going through it with her. And in like the nicest possible way, she was like, I'm really sorry, but I think you have me confused with someone else. I don't know any of this. Right? And I'm sitting there going like, happening right now? Like, I'm like so peaked, or like just like what is happening? And she's just like, I don't know any of those people. I'm like, this person and this person and this person, like you brought them all up, and you were really like up and acting really different last week. I wanted to talk to you about it. And she's like, that's not me. I think you're confused. It took everything I had, all of it. It took so much for me to be patient and not be like, you're the one in therapy, not me. You're like, I'm not that. Like, it took everything I had, and like something inside me was like, this is really important. I can't let this go. Right. And I was like, we literally went back and forth for like 20 minutes. I was here. No, I wasn't. I was here. No, I wasn't. Right. And I was like, okay, every time that you come in, it's videotaped. Like they record you, and you have to watch it in supervision. It's so painful, right? But they record the sessions. I was like, do you mind if we pull out the tape from last time and let's watch it, let's settle it. So she's all like, she had that like, yeah, well, we're gonna see how wrong you are. And I was like, yeah, we're gonna see how wrong you are, right? So we pull out the tape, my supervisor comes in, because something is obviously really off here, right? And I was right, she was there, right? I was starting to question my own sanity for a moment. But we sit down and we play the tape, and she just starts sobbing. She's like, that's me, but what am I wearing? Who am I talking about? I don't remember that. I'm just sitting there going like, whoa, this is so wild. Right?
Your hit of heroin, right?
What?
I said it was like your hit of heroin.
It's crazy.
As
Yeah.
a therapist, right? Like,
Yeah. I was like, this is why I'm in this field. This is amazingly interesting. And she's just like, I don't remember this. And it turned out she had been having these blackouts, which are really common with this disorder, where she didn't remember these periods of time. She had created another identity that was outgoing and extroverted to try and help with the struggles of being so introverted and struggling being away from home. And when she switched to this other identity, she had no memory of it, right? I had to refer her out. I never saw her again. I wonder to this day what happened with her. Like, so maddening. I'll never know, right? But like that was the one time in my life I've seen this in person. And she was so genuinely confused that like, if I ever wondered if this was faked, and not to say that people don't try to fake it, people do try and fake it, especially in like criminal cases. People try, oh, my other personality did it, right? But she sobbed seeing herself on the like video and not remembering that moment. Like it was just so confusing for her. And it was like one of those moments where like I will never forget it. And it was just so rare, but that's the one time I've ever seen this. And she had is probably here, right, where she had like a dominant. The dominant doesn't always have to be your main personality. It can become one that you create, right, and that makes it even trickier to deal with, yeah. Yeah, if they, unless they're here. Usually cognizant doesn't have blackouts, right? They tend to remember everything. But if they haven't one of the other two, they typically do have blackouts and they don't remember periods of time. Yeah.
Is your dominant personality always the most aggressive of the people?
No.
Or could that mousy person actually
Yeah.
be her dominant and then?
It's usually your main identity as a person is typically the dominant, but not always. Sometimes one of the dominant or one of the like submissive ones, the new ones that are created, becomes powerful enough to take over, right? Or they like spend so much time as that individual that they take over. And these can be subtle. Like it can be super subtle or it can be incredibly dramatically different. There's just so much variability. But it's not usually as like as wild as they portray it in the movies. Not usually, anyway. Yeah.
So like, what's the personality splits? Is this like a permanent condition? Or
No. There are. So it's not permanent. It can be, but the most common way to treat this is a technique called fusion. And so, and really cool in this movie, the whole movie is about fusion. Not so rude. The whole movie's about fusion. Really cool take on this. But what you have to do is make those subs worthless. So you kind of have to confront each one. You have to recognize the nature of the disorder. You recover gaps by helping them like journal. Different personalities can have different handwriting styles, different like words that they use, different ages. It's really wild to see. And then you have to find a way to integrate them together. So you basically make their purpose like you remove their purpose and then the identity tends to go away. So you have to do that systematically until you get down to one or as few as possible. Were there other hands? Yeah.
Like the born identity,
Yeah.
would that be like dissociative identity disorder or dissociative?
I would say it's more the dissociative amnesia, though I have to admit, like I watched the first like 3 and then I kind of lost interest at some point. Like, so I don't know how it ended. But like in the ones that I watched, I would say it was dissociative amnesia, like forgetting your identity rather than creating another identity, if that makes sense. So this one is like 2 or more identities that routinely take over. The most common is 3. The highest documented was 126, I want to say. Like usually it's like 2, 3, 4. It's not a lot, but it's enough that like notice it. Yeah. Yeah. Any age, right? It can happen at any age. It's more common when you're a little older, but when we old, young.
I've heard it. This is probably quite funny. It was a small girl, like, it was almost out, but I only saw it when we're kids.
Yeah. And it's harder to, sometimes it's harder to pick up in children because children tend to have wild swings of like behavior and emotion changes anyway. But it can be when you're young or old at any age. It's totally possible. Is there another?
Great story.
Yeah, and it was so well, I'll never forget it ever, right? Like, I mean, it's just, it's there for me forever. And Freud would say it was caused by repression, right? Like it's an extreme repression. You have something traumatic happen so extreme that you repress the personality, right? To the point where you create a new one. And so you have to go through and bring that back up through things like hypnotherapy, which we talked a little bit about earlier. This would be a case where hypnotherapy could be really helpful because you get through that cognitive barrier enough to bring that other personality forward, right? So you're doing things like hypnotherapy, but the main way of treating this is this 3-step process where you help them recognize what they have. And this could take a while because you have to tell each personality when they emerge. And if they're not aware of each other, you have to wait for them to come forward, right? You educate, then you recover gaps in memory through journaling, and then you try and fuse them by getting rid of the purpose of one of those identities. Yeah.
Right, so, sorry.
No, it's fine.
If you have like 1 or 3 instead of 2 in that hall, and then also one great experience blackouts, but that also mean that if those personalities were like, let's say, run wild, would the other personality not have access to the information?
Right. Yeah, if they don't share memory,
Yeah,
then only one, and that might be like the most obvious way, you switch, and now all of
Yeah.
a sudden they're speaking another language. Right, and, that's not common, obviously it's kind of like an extreme example, but it's possible.
I was just asking, maybe to like make it sneaky, like,
Sure.
children have some early on.
Yeah,
Children have to go to school every day, the teacher's gonna pick up on whether or not one.
You would hope.
Respond to Billy every day, and
Right.
they just don't respond to their name,
right,
you know?
yeah. It's bizarre, and it's usually not super dramatic, but it can be. I mean, there have been cases where like the personalities are just so markedly different. And so, like I mentioned, Bates Motel, one of my like probably favorite shows, like psychologically of all time. And then they had the woman who played Lorraine Warren in it too, right? So I love that because of connection to the horror movie. But what I loved about that was he creates a personality that is a version of his mother, right? And so like it's his mother that he creates in his mind. And he doesn't have memory for the murders he commits when he's as his mother, right? And eventually it starts to come up through therapy and you start to identify it a little bit more. But his shifts are hugely dramatic. For some, it can be so subtle you might not notice. It can be really hard to see. Did you have a thought? No, you're fine. Yeah.
So like, it's related to trauma, but like, are some people more susceptible because of
Mhm.
like how they are genetically, or like?
It would more be your like, the thought would be more that it was like how you were raised. Maybe you had a difficult, traumatic childhood that kind of sets the stage. You didn't learn good like emotion regulation skills as a child. I mean, it's thought that some people are more susceptible, but it's pretty rare as far as disorders go. It doesn't happen a ton. And so it's thought more to be environmental. There's a lot of environmental factors, like you didn't learn how to regulate your emotions well enough. And so this is like an extreme form of regulation in a sense. You're repressing like the part that you can't handle and creating something else that can. It's wild because you have to get rid of that purpose in order to get rid of the personality. Take some time. Like, so like with my client that I never saw again, it'd be teaching her social skills, helping her become a little more extroverted. You would get rid of that extroverted personality because it wouldn't be needed anymore. I could have helped her. I didn't get it. I could one day anyway, one day, right? Any other like thoughts, stories, questions, anything for now? We made it through, right? So again on Monday, I don't want to end because I'm not going to see you for a while. I just had a moment of like, no, I'm taking all 5 of my leftover minutes. So Monday, don't forget about the exam. Again, if anything comes up, if you have an emergency, please reach out to me. Otherwise, make sure it's done by the deadline or it's closed because just please be really mindful of that. Don't forget that I won't see you for those like 2 weeks after, but watch Canvas. If you're not set up on Canvas for notifications, make sure you do that. So we'll be sending announcements regularly. I'll be checking in with you. You can always email me if you have questions over that time. Hopefully I will see you on, I think it's Monday, 10/6. That feels so far away from now, but I'll see you in like 2 weeks. Good luck on the exam. And again, feel free to reach out if you have questions. Right? Thank you. Thank you so much. I hope that it's the shorter option.